Hello everyone. Today I am going to tell you the last part of Principle of Management of Thalassemia Major. Prevention of the thalassemia by antenatal diagnosis and genetic counseling. So prevention by the genetic counseling, we should do the counseling at every level to prevent the thalassemia major. So premarital counseling should be done, then preconception counseling, then in antenatal period, prenatal molecular diagnostic tests should be performed to screen the fetus, then after the birth of affected baby. In premarital counseling, before marriage, in high-risk individual, example in Punjabi, Sindhi, Lohana, Bania, Bhanushali, Kathiawadi, thalassemia is more common. So in such communities, we should go for a screening program to identify the carriers. So by the screening program, we can label them. These are the thalassemia carriers. So at least two carriers should not marry. So reproductive teaching of adolescents should be done, especially in such communities. We should explain them thalassemia is an inherited disorder. It will be passed on from parents to the children through their gene. Child cannot develop the disease unless both parents carry the thalassemia gene. So premarital counseling of adolescent girls and boys in these communities should be done. What are the screening tests for the carrier detection? We can go for Nestrov test, naked eye single tube red cell osmotic fragility test. Details of Nestrov test generally asked in the Viva. So in next slide, I will tell you the detail. Red cell indices, low MCV, low MCS suggest that patient may be having the thalassemia carrier. Hemoglobin electrophoresis, in which elevated hemoglobin A2 is the gold standard for the confirmation of carrier state. These tests can be false positive, so in other conditions also. So to confirmation for the carrier, we should go for hemoglobin electrophoresis, and molecular genetic test will also confirm the carrier state. In Nestrov test, we have to take the two test tubes which will be labeled as a BS and DW. BS is buffer solution. We have to take the 2 ml buffer solution in one test tube and label as BS, and another test tube in which distilled water 2 ml should be taken. Drops of blood we have to add in the both the tubes. Then we have to left it undisturbed for half hour at room temperature. Then after half hour, content of both tubes should be gently we have to shake and held against the white paper on which we have to draw the thin black line. So in this image you can see this is the thin black line, and these are the test tubes, and this test tube with the buffer solution also black line is visible suggests the negative test, while in this test tube it is also the buffer solution. Here the line is not visible, so this is positive, and this is the distilled water tube. So if after we held against the white paper on which the thin black line was drawn, we have to see the line is visible through the distilled water or buffer solution or not. So if visible through both distilled water and buffer solution, we will label as a negative test, as in this case. If clearly visible through distilled water but not visible through the buffer solution tube, then we will label as a test positive. After that, we have to keep the tubes undisturbed for 3 hours, and after the end of 3 hours, distilled water tube was seen to be homogeneous pink with no sediments will be there. While in the buffer solution tube, if test is negative, similar finding as with the distilled water tube. While in the positive case, in carrier state, clear supernatant fluid and a sediment at the bottom will be observed. So will be considered as a positive. Now the prevention at the level of preconception. So preconception counseling should be done. We should explain them mode of inheritance of the thalassemia major. It is autosomal recessive and risk of having the child as a thalassemia major 25% if both father and mother both are carrier. So if both are carrier, then there are 25% chances that baby will be normal, 50% chances that baby will be carrier, and 25% chances that baby will be having the affected child thalassemia major. So we should explain them preconception counseling should be done. So there will be probability of 1 in 4 children having this disorder. We should also explain them about the option of pre-implantation genetic diagnosis, and they can decide the future of the baby involved. Now, the other level of prevention is prenatal counseling when the mother is already pregnant. So we have to advise them for the molecular diagnosis of the fetal tissue for the affected or not affected, as there are chances of 25%. So there are invasive methods and non-invasive methods. So in invasive method for the sampling, amniocentesis can be done between 14 to 20 weeks of pregnancy, or chorionic villus sampling can be done between 9 to 12 weeks of pregnancy. In this, PCRs, reverse dot blot analysis of the fetal DNA should be done for the analysis of affected with the thalassemia major or not. There are various non-invasive methods in which they analyze the fetal cell DNA in maternal circulation by the PCR, digital and multiplex PCR, or next generation sequencing. Nowadays, they prefer the non-invasive method. So we should give them the option for the fetal diagnosis for the thalassemia major affected or not. This will be helpful for the parents to decide whether to continue the pregnancy or not. If the child is affected with the thalassemia major, they can terminate the pregnancy if they are willing. We should prepare the parents for the birth of affected child if the fetus is having the thalassemia major. So prenatal counseling should be done, and we should give them the option for the diagnosis. Now, after the birth of baby, if already thalassemia major baby is delivered, then we should educate the parents about the treatment options, what are the possible complications, what are the curative therapy for the thalassemia major. And we should advise them HLA typing of the sibling fetal DNA in next uh, pregnancy to check whether HLA identical, so the suitable bone marrow donor available for this child. So this is all about the prevention. Thank you so much.